Yeah, so for those who are just joining in, my name is Max Ortiz Catalan. I'm the director for the Center of Bionics and Pain Research, and I'm the professor of bionics at Chalmers University of Technology. And I got into the study of pain because when I was doing my work on prosthetics, I met few patients whose main problem was pain. So I really realized that for many patients, pain takes precedence over anything else. So I come from an angle that is say more practical and oriented to solving the problem. And you know, I got very interested in pain because it's a very complex experience. And there are some reports that I found very interesting on the side effects of lobotomy. So doctors realized that patients stopped complaining about pain after they underwent lobotomy. So they thought, oh, well, you know, now we have a cure for pain, or like severe pain. So when they went and interviewed them, they said, like, well, you know, you stop having pain, that's great. It's like, well, actually, no, I still have the same pain, I just don't care about it. And that tells you, you know, how complicated the pain experience is. And you know, this has been observed and it's documented since a long time ago. So another example, so before I jump to that, if we look at the official definition of the International Association for the Study of Pain, they have some keywords here that is unpleasant and emotionally taxing, if you wish. So based on this definition, what these patients were experiencing was not pain. And whether we can debate that it's, you know, it is not, or if it is or not, and if it's okay to leave somebody who's experienced pain but doesn't care about it. And I'm sure these are questions that have been debated when the group that was discussing these definitions is. All what I want to say is that measuring pain and what we consider pain can be tricky and can influence a lot of the studies and the results we report and our understanding of how the whole thing works. So for many people, this is my own experience, for many people walking barefoot on ice is painful. And standing 15 minutes on ice digging a hole, it's painful. And then going inside the ice, it's you know, painful. So when I do this, I feel like 1,000 needles on my skin. It's not a pleasant sensation. You can make it, you know, pleasant by smiling. Some research in psychology shows that if you smile a lot, you'll be happy. But there's mental aspects that can mediate the experience of pain. So there are a few things that I think we should consider when we're talking about pain. One of them, there is a material effect caused by the treatment. So if we think about neuroma pain, and we remove the neuroma, do TMR and so on, there's a material effect for that. Then there is an unconscious material effect of placebo. And that can be mediated by, you know, different ways, and there are different placebos. And then we go into the definition of what is a placebo. But there is also an important, more conscious and intentional aspects and mental states that will change your experience of pain. And that can be, you know, self-efficacy, for instance. I'm quite intrigued of what is actually self-efficacy and what it does, and if we can consider that as a placebo. So the way I, you know, try to picture this and making sense of it is that there is certain intensity of pain, and then there's a noxious stimulus, and then you will feel pain based on your genetics and your previous experience, right? So that'll be your personal experience of pain. And then from there, if you catastrophize, that experience will become worse. And then if you use other techniques like self-efficacy, say, but self-efficacy actually is, or say meditation, if you practice stoicism and so on, you'll be able to dampen that response. So there's a baseline that is relevant to physiology, and then some psychological aspects that will take place. So, and that is, I will argue, the same for neuropathic pain as well. Once the experience, when you start feeling the pain, then you will add those other factors. So the International Association for the Study of Pain defines, or to be honest, there's one page on the internet. It's probably not even a formal definition, but that's everything you can find regarding to phantom limb pain from ISP. Phantom limb pain related to the location. Stump pain is in the stump, phantom limb pain is perceiving the phantom. And of course, the issues to differentiate these two are quite obvious for anyone who has a bit of clinical experience. Telescoping is a problem. The pain can be perceived in the area of the stump because the the phantom is retracted. So something that is important to consider is, as we hear a lot today, but sometimes it seems to be forgotten, pain is multiple realizable. There are different causes or different triggers that can get you to experience a painful experience. And if we look at the healthy system, is on the alarm system that pain was intended, or that is useful for, is when there is tissue damage, there are these signals that are or this damage is picked up by nociceptors, brought up to the brain, some processing happening, you experience pain. In the case of an amputation, you have these neuromas forming, and therefore, because there were these nociceptors innervating the missing hand in the same way that when we stimulate tactiles, for instance, the people will experience sensation of touch. If those nociceptors are stimulated, they will experience phantom sensation. And for these, today, there have been a few clinical trials on surgical techniques that can address neuroma pain. We're actually running or starting a clinical trial looking at the efficacy of the different clinical techniques to take care of that pain. So, but it's important to differentiate between pain that comes from a neuroma versus neuropathic pain, although by definition the neuroma will fall into the neuropathic pain. But if we try to be a bit practical here and give you some room to explain what the situation is, that'll be the difference. So a couple of years ago, when I started looking or trying to make sense of phantom limb pain, I realized there would be a more practically or clinically useful definition to separate neuroma pain from phantom limb pain and leave phantom limb pain to only those causes as a definition that is excluding nociceptive input. And this is something that I would like to discuss in the panel with the clinicians here to see this, because again, it's important that, because there are no clear guidelines for therapists to treat patients, it's important, I think, that people know that they should look at these different origins so they provide the best treatment for the patient. And again, the point is, this is important because if you have a patient with neuroma pain and you do a cognitive therapy or plasticity-guided therapy or something like that, you might get some improvement. But I mean, if you really treat the neuroma, you get rid of that nociceptive input, then you'll have a better improvement. You might not even need the other part. Of course, if you combine them, you probably do better, right? And that's what a lot of pain treatments are about recently, a combination of cognitive approaches together with something that will have a physical effect. So we said this a lot. There are many therapies, and I have a hypothesis of why. But we know that nothing works. That we don't have something that works all the time for everybody. And there's obvious side effects on medication, and probably the worst part here is that is pain management. It's not really addressing the underlying situation. It kind of makes sense that if phantom limb pain is there because there is no limb. If we have a highly integrated prosthesis, for instance, some of the work we do that we call neuroskeletal prosthesis, these are prostheses that are connected to the skeleton and to the nerves and to the muscles, and more importantly, patients use it every day, for years. So for these patients in any environment and so on. So it's uncommon for these patients to really have phantom limb pain, and that just kind of makes sense. But it's difficult, it's difficult. This technology requires an implantation, and not everybody is suitable for it, and so on. So we look at plasticity-guided treatments. We know about motor imagery, which been proposed as a treatment by itself. Then we just hear a lot about mirror therapy, and then you can see some of the differences here. So in mirror therapy, you have the visual feedback, and however, something that is uncertain, and that's why I was asking Professor Tao, is what were the instructions that were given to the patients, because I have seen clinicians tell the patients, imagine a movement, and I have seen some others tell them, try to do the movement. And there's a bit of a difference between trying to execute something or just imagining the movement. And then, because engineers got involved at some point, and we have gadgets and we like to use them, then these virtual reality treatments came out. And most of these treatments are effectively a virtual mirror therapy, because the control is derived from the contralateral. So whether the patient is doing phantom movements or not, you cannot verify it. So then it becomes like mirror therapy at the basis. So something that we've been exploring for some time is driving the control using molecular pattern recognition, and this is mostly because my work on prosthetics. So you've probably seen this video many times, so I'll just show it for someone that is joining a new phantom limb pain. What we have here is electrodes on the surface of the skin and a standard screen and a webcam. The patient sees himself like in a mirror. We put a marker on the stump, we do image processing on the video, and then we add a virtual limb. And now the patient see themselves with a virtual limb. That's what's called augmented reality. The difference with mirror therapy here will be that the patients move that or control that virtual limb using movements that will correspond to their phantom. So we try to get them to use their phantom as much as possible, and not only with an anthropomorphic visual feedback, but also playing games. And in this case, the patient is driving that car using phantom movement. So he's rotating his wrist to the left, the car goes left, rotating to the right, car goes right, flexing the elbow, accelerates, and I think about there he's going to extend. Maybe he did that already. There. So the car brakes. And that can be any movement of the phantom. So the purpose here was to get the patients to engage in as much phantom movements as possible. So we first tried this in few single case studies. We did a multi-center clinical trial on 14 patients with chronic intractable phantom limb pain, meaning that in average they had phantom pain for about 10 years. They tried everything else that was available in the hospital. And then we had a reduction of about 50% in pain that lasted for up to 6 months. And some of the major benefits that we observe here is that the intrusion of pain in their activities of daily living, and particularly sleep, was dramatical. So they could sleep better, and that had a positive spin on his whole life and the perception of pain. So it's been shown that if you're sleep deprived, your experience of pain is worse, and then you can't sleep, and then your pain gets worse, and it's just this bad cycle. So this started as an open source development, and then the product was given to, or the idea was given to Integrum as a company, and they're commercializing it now. There's a CE mark product. And from there, we look at technologies to enable it for lower limb treatment, and then we've shown that with this, it's relatively simple to use, so it can be done at home. And because it's not an invasive device and it's relatively easy to use now, it's been used clinically in many countries around the world. So from Australia to South Africa and South America and a little bit everywhere in Europe. And we are now doing a double-blind randomized clinical trial, which we published the protocol in 2018. We recently published the statistical analysis plan, and now we're going to start looking at the data, so we're making it as rigorous as possible. But all the data is not in yet, so I'm not going to speak about this yet. So expanding a little bit on these ideas of phantom limb pain, I was quite interested to understand why this treatment had any effect. So then I look at the literature, and I found this idea, of course, of pain memory relating pre-amputation pain with phantom limb pain. Then there is this sensory motor incongruence idea that you hear about. Patient tries to move, there's no sensory feedback corresponding to the movement, and then pain exists, which I find it to have a rather big explanatory gap in that jump, but I'll speak about that a bit later. And then there's the idea of time to differentiate on how, because the amputation happens so fast, then you have phantom limb pain. So maybe if it will be a slow degradation of the fibers, phantom limb pain wouldn't be there, or the phantom itself. And then there's been a lot of studies on the cortex. And while I see this as correlation with phantom limb pain, I haven't got to understand how the body representation and cortical changes relate to pain. So I'm still missing that explanatory gap between changes in the cortex and pain. So all these, we can debate all this plasticity stuff, and that's interesting, but what I would like to know is how do we get from there to pain? So because I had these issues, then I proposed a new idea called the stochastic entanglement hypothesis for the genesis of phantom limb pain. So pain memory, there's mixed evidence on this. There's studies that show a statistical significant and not in pre-amputation pain and post-amputation pain. Practically, if it is true or not, we should deal with pre-amputation pain anyway. And we have a patient with phantom limb pain now, knowing that it was because of the pre-amputation is not going to help that patient today. So I think this direction is not taking us very far. So the sensory motor incongruence idea, so it was a paper. The hypothesis was published in The Lancet, I think, in 1990 or so, by Harris, and there was a very strong focus on visual feedback, particularly anthropomorphic visual feedback, where it was said that treatments that prioritize visual feedback will be probably more effective. And although that is intuitive, I can see how that can be true, because somatosensory feedback seems to be a lot more important. That's what is lost. So proprioception, touch, all that circuitry is gone. So the time in which the onset of the time for this hypothesis doesn't work very well, because we know some patients can have phantom limb pain after many months or many years. So, and we know this learning paralysis effect. So patients will stop trying to move by a couple of months after the amputation. So I will doubt that they are trying to do movements later on that is causing the pain to come in. But the other thing is that many studies that have shown there's a correlation or inverse correlation between the ability to move the phantom and phantom limb pain, which will contradict this hypothesis, because then those patients who are moving their phantom, they have this sensory motor incongruence, yet they don't have phantom limb pain. And there are a few studies that show into that. And I mentioned the temporal characteristic. The time to differentiate it, well, that was maybe put to rest, hopefully, in a study done in leprosy, where it's been shown that in leprosy you have a gradual degeneration of the nerve fibers, and yet those patients still have phantom limb pain. So it's not necessarily related to how long it takes. So then we got to the cortical changes, and there's been a lot of research conducted on this. There's been mixing results. I think now we know, and a lot of work has been done on that, that it could be related to the methodologies. But even in the same studies where the same methodology is used, there are mixed results. But then to me is the question of, okay, the cortex help us to localize pain, because pain has to be embodied. So the experience of pain has to be felt somewhere. But a stimulation of the cortex rarely causes a painful experience. What Painfield was doing, the maps, it was very few times that the patients will report pain because of a stimulation of the cortex. So if we can generate it directly, or it's hard to generate it directly from the cortex, then my question is, and that's what I would like to discuss later on the debate, is how is it that changes in the cortex has any initiating or triggering effect on phantom limb pain or help it to maintain it? And that's the explanatory gap that I was talking about. And that also take me to some of the comments that have been said and body representation. So certainly there might be, or forget about certainly, there are probably some changes on representation of the body. How is that connected to pain is the question that I'm interested. So the idea, very briefly, with stochastic entanglement, so there's a few premises. And the first one is that we have a neural circuitry for pain processing, and we have one for somatosensory sensory motor processing. And these are linked because, as I said before, pain has to be felt in the body. So there's this obvious relation between those two. And they're normally in a healthy state, in a stable situation. And for those that are more into physics, which is maybe today only Malin and I, but we can see this as an attractor. There's a stable situation. That's what you can think of. And we hear today that there's spurious activation, there's spurious activity in these neural networks. But when the system is stable, this causes no major issue. They're unnoticeable. However, in an amputation, there is a considerable change on the neural activity related to somatosensation, because there's no sensations coming anymore, and there's no motor activity produced. And that can bring the system into a more susceptible state in which these notorious, these spurious, stochastic by nature activations can initiate pain, and this undesired perception that is very noticeable then can have different temporal and qualitative aspects. So that's the idea, and now how we work it out, and I have had some discussions with people and said, okay, well, it should be more specific. Then I was thinking, okay, when Darwin came out with the theory of evolution, didn't know about the DNA, right? So there's some there are some facts that we can observe to put an idea forward, and now we're trying to find what are the details of how can that might happen. So we look at modeling of pain and try to we made a review on what could we use to do that, and we see some ideas, and now with one of my PhD students, Malin Ranmi, we try to find ways in which this could happen, and then later on test them. So along with that, we've done some brain imaging studies and search for neurocorrelates and try to find something over there. But what I can say now, if we consider this idea, and this is in the paper, there are a few predictions made by this. So the first one is that because I'm talking about the sensory motor circuitry, anthropomorphic visual feedback is not as important as I believe is believed to be. So that's one of the predictions or conclusions of this idea. It doesn't mean that it's not useful, and I'm talking about anthropomorphic, meaning the representation of an anatomical limb. So one of the reasons for that is that, well, patients see other able bodies moving their limbs all the time, and that doesn't cure pain. We know that passive prostheses that look like limbs don't reduce pain. It's only when they're active. And I think for me, the strongest part, and is related to something that Professor Cervero said, there are these visual illusions, and saying that vision will do that at the fundament, it will mean that the visual illusion will permanently or have a long-term, long-lasting effect on the neural circuit. And as we saw in his illusions, as soon as the illusion was removed, you could see back what you have to see. Saying that visual feedback of a limb will change your neural circuitry so you stop having pain is saying that that input is enough to change your wiring so you stop having pain. And I think that's a bit of a stretch. And because let's say big claims require big evidence, so then that's why I'm a bit skeptic about that. So why does phantom motor execution works, and does the treatment that we're proposing? So based on the idea of the stochastic entanglement is that if we re-engage as much as possible the neural circuitry that was affected by the amputation, we're going to get them to do something useful rather than help processing pain. And that has also the consequences that we expect to see an enlargement of the cortical representation on the stump and the preservation on the other neighboring area. But continuing with that, this idea has other predictions, meaning that VR treatments that exclusively focus on a realistic visual representation will not have a major effect for what I just argued. Also, if you use as a control for the virtual environment the proximal joints, so the Kinect system, sisterized globes, and so on, will also not have an effect because you're not focusing on the phantom. And whether, and this part of I think was one of the questions before, whether you use a screen and a head-mounted displays, it's irrelevant, because as I said, anthropomorphic visual feedback doesn't seem to be, or what I would like to discuss later today is what will be the basis for that to be important. And so I've seen few reviews on virtual reality for phantom limb pain, and to me this is not. This is not correct, because virtual reality is a tool. It's not a treatment by itself. It would be like taking a syringe and saying, we're going to look at the efficacy of vaccine by looking at the syringe. It's not the tool, it's what is inside. So how you use virtual reality is very important, not just virtual reality by itself. So to quickly ask some questions, so the time, the onset of phantom limb pain is because we have this stochastic nature. It can be basically at any time. Something that I didn't write here is a prediction that this will make is that the incidence of phantom limb pain will be higher in hands than in legs, just because the amount of neural circuitry is higher, so you probabilistically it should be more, the incidence should be higher, and I believe there's some evidence to point out to that. What about interventions that reduce phantom limb on the spinal cord? Well, if you listen, I've been a bit careful talking about pain circuitry and sensory motor circuitry, and that's along the whole neural axis. So this can happen at any point, this undesired entanglement. In one of my early presentation about this, I was said, okay, well, but if you engage in the neural circuitry, why do we have patients with TMR who has phantom limb pain? And I was thinking about that for quite some time. I said, well, yeah, actually, why? But it turns out that TMR, you do a hyper-reinnervation, right? You have this thick nerve, and you put it in a smaller one. And so you don't have as much as the neural commands and the sensory feedback as you might need for all patients. And that's why few of those patients will have phantom limb pain. And some patients with phantom limb pain who had TMR and have done phantom motor execution, where they have focused on movements that are not on their prosthesis, meaning the prosthesis have rotation, hand open and close, and elbow flexion extension. We get to do hand flexion extension and say finger control, then they have found an improvement. And that will be potentially because now we engage in a larger amount of the affected neural circuitry where maybe this stochastic entanglement happened. Mirror neurons. So true, there's this very interesting mirror neurons that will respond when you see somebody moving, and that might be enough for somebody for whom this undesired entanglement happened around that area. But taking the whole neural circuitry, this is a very small part. So I wouldn't say that will be the most effective treatment. Which brings me to mirror therapy. So the prediction, so based on this hypothesis, the reason why mirror therapy works, I believe, because there is evidence that it works, not for all patients, but it's useful, is more related to patients trying to execute movement than the visual feedback they receive. And I think so. This is something that can be tested empirically, and there's some evidence against and pro this. There's some studies that have shown that even with the mirror cover, patients have found relief of pain, not in the study of Professor Sao, though, but it's been there. So I think that's something that we can still study to see if it's true. And this is quite important. It seems like anything we do to the nerves or any virtual reality or something, like it has an effect on pain. And there's many studies published in a few cases that, we did this with a patient and there's an improvement of pain. And if you thought that my introduction had nothing to do with pain, there are these three different factors, right? So there's a placebo effect, there is the psychological effect of somebody being brought to a clinic, given the sense of understanding of what phantom limb pain is and some hope that they can deal with it. And that will be related to self-efficacy. So there are all these other mechanisms that are not necessarily the treatment itself that can produce an improvement of pain. And then the business of embodiment. Well, I see embodiment as a second order result, right? So what I said is that if we engage the neural circuit that was affected by the amputation, that means that we have the motor commands that will produce agency. We give sensory feedback that will produce ownership, and that builds embodiment. But it's not the embodiment that's causing the relief of pain, is the engagement of the neural circuitry. So this comes as a second order effect, I believe. So not all our patients got better with phantom motor execution, and if you now just follow this idea that what matters is engaging as much as possible of the affected neural circuitry, then it just follows, and there's been some work done by Professor Floor on sensory training by itself. There's indications that this could work, so now we're mixing on what we call mindful sensory motor therapy, and we develop an actuator that is designed to optimally stimulate the different mechanoreceptors in the skin, and now we're testing a treatment in which, for instance, here it's the standard breakout game. You have the person having the paddle. He doesn't see the paddle. He's using the sensory feedback that comes from the device on his arm to know where the paddle is, and he's controlling the ball using EMG. And this is the level 1 kind of approach of this therapy, and then things get more complicated because we want to extract, make the motor control more complicated and make the sensory feedback more complicated. And on top of that, we're looking at brain modulation to improve pain for a different reason that brain modulation is normally used for pain. There was a study a few years ago that showed that TDCS improved molecular pattern recognition, and a lot of our work is based on molecular pattern recognition. So the idea is basically, if we get patients to get faster or to get better at molecular pattern recognition, then their improvement will go faster. And now, but it's also some work, and we'll hear about that by Professor Bolognini on Wednesday, in which TDCS alone has improved. Thursday, my bad. Yeah, Wednesday is the surgical stuff. So we're also developing an open access mobile app to track pain. Measuring pain it's a problem. So we really try to find ways in which we can not only have a single point in time, but we have a profile, because pain, or particularly phantom limb pain, can change during the day, can change during the week, and can change during the month. So we're looking at tools for that. So that's some of the people in my group. It's been a few people in the past, and now we have different students and postdoc working in mostly prosthetics, and now the pain group is getting a little bit bigger. We collaborate with different institutions around the world. There have been some of our work done on documentaries and stuff on social media that you can find if you're interested, and I can take some questions now.
All right, yes, we have a few questions. I will start with this one. Cortical reorganization is a maladaptive plasticity process, and is therefore an explanation for chronic pain.
Stop. So what I would like to know is how that. So that's how is that related to pain? The cortex is very much mapped for tactile sensations. I have some neuroscientists here, but do we have a pain map, or how that change connects to pain? That is the part that I would love to understand. But sorry.
So the second part is the question: is the stochastic entanglement supposed to explain both acute pain and the process of becoming chronic?
No. It's more for neuropathic. Because I think acute, and that's why I was making the difference in the beginning about neuroma pain, where you can go and stimulate the neuroma, and you can have. You don't need. I don't think we need more explanations for that kind of pain. So it's mostly relevant for what you will say, and as I said, for phantom limb pain that is related to other factors than the stimulation of nociceptive fibers.
All right, so we have another question, similar. Is your stochastic entanglement theory specific for PLP, or can it be tested in other group of neuropathic pain patients, or acute pain, for instance? And which brain networks are causally involved? So
thanks for making a theory. I don't think it's at the theory level yet. It's still a hypothesis, and so we're trying to test it. I believe that, and the reason why our work is in pain due to sensory motor impairment, if the reason is the low level activity on the afferents and motor control, then this will also apply for pain due to nerve injuries or a stroke and so on. So it seems to me that this affects pain due to sensory motor impairment in general. The other part, what is the what?
So other populations and acute pain, and then the final part of the question is which brain networks are causally involved?
That I don't know. So that we're trying to find it out. So our first models are on the spinal cord, actually. So we're gonna go bottom up. So we're starting with models at the spinal cord, and then we're gonna get things more complicated as we go up. But as I said, we don't. This is going from first principles, and the principle being that there is an affected network that is underutilized, or that just go underutilized, or that is just not as active as it used to be, and it's a substantial amount of neurons related to that.
May I just add one?
Yes.
I think in back pain and in fibromyalgia, in all pain problems related to the musculoskeletal system, we also see a lot of sensory motor dysfunction.
Okay.
This will also work.
So it could be related to other. Thank you.
Perfect. So next question. To test the efficacy of augmented reality therapy, can you describe what placebo-controlled therapies you use? Do they control for patient entanglement, expectation, etc.? Engagement, sorry.
Glad you ask. So the control that we're using for our therapy is that the patients are using the same equipment. They wear the same thing. We put electrodes. They use the same virtual reality. They get the same experience, other than in the treatment that I think will do best. I can't talk about the results yet, but they do the movement and they control everything that is happening by doing the movement. In the other one, the limbs and the games move autonomously, and they imagine that is them doing the movement, and we use the electrodes to prevent them from doing contractions. Because what I wanted to separate was the execution part and the imagination part. This is not a perfect, because we're using EMG, meaning that there could still be some activity going down to the muscle that we cannot measure. And I'm actually almost certain that that is the case, because we get a lot of alarms, at least in the beginning when patients are using it, because they at some point they try to do the movement. Something else?
Yes. So we have a rather long question. Comment to a question about cortical reorganization information gap statement. Cortical reorganization information gap statement. Some of the rudimentary pathway signals that go to spinothalamic tract project to periaqueductal gray area, important area for chronic pain propagation. And then I need to find the other part.
So, without going into much details, if this is certain, what I'm surprised of is that I don't that I don't hear more about this when I'm reading the papers, right? So I don't know how certain we know that connection is super important and will be relevant.
So the final part of this question was perhaps somatosensory reorganization is the byproduct versus the etiology of the condition.
It seems to me the case, and that is a consequence that it's a consequence of losing a limb, but then the pain, it's been kind of like merged into this consequence, but the pain part is not entirely clear to me how that relates to those changes.
All right, so we still have a few questions to go.
I want to say about before I forget, about the blind patients. So in the paper, I hypothesized the same. So the consequence of the idea is that if there's a person who is blind and loses a limb, I believe will still develop phantom limb pain because of the somatosensory feedback and lack of motor control. But we can still treat her with other kind of sensory feedback. So that will be, for instance, a prediction that is made. And what I would like to exhort the field and all the people that are doing research here is that when we talk about these ideas, we also try to make predictions that can be falsifiable. So we put the idea forward, say like, oh, these old things happen. So I'm already saying, how can I be wrong? And I think that's something we should try to do more often, so we can say like, okay, this idea is not true, then let's move to the next one.
Okay, so I have there are many questions, so I'm going to ask one more, and then the others are going to be kept for the panel discussion. And I'm going to ask this one because there are some similar. So what do you expect from the use of sensory feedback in treatment of phantom limb pain in addition to motor execution? And similar, have the patients, when your advanced prosthesis with sensory feedback, gotten completely rid of phantom limb pain?
Most of them. So there's a few things there. So most of the patients, we have one patient that's struggling a little bit more with phantom limb pain. All the first ones have no issues with phantom limb pain. About the real-time stuff, we have a patient who puts the arm and his phantom takes over the arm. As soon as he removes it, the phantom retracts. And that seems to be more related to the representation of the phantom. What was something there in the beginning?
Your expectation about the use of sensory feedback?
Yes. So I'm trying to find data, and hopefully somebody can help me here. There's anecdotal evidence saying that when you cut a sensory nerve but not a motor nerve, you get phantom limb pain. And then I read some papers that says completely the opposite. So I don't know what the real true is here. what is the difference between the sensory and motor part? I think that's something that we would like to investigate. Maybe only one is relevant, and because sensory and motor are not entirely separated, they're very linked. We're using motor because it's easiest. It's a top-down thing, so the patients can try to do movements. To produce sensory feedback at the richness, at the level that we will be able to stimulate a lot of the neural resources, will require the high-resolution interface that will be implanted in the nerve, which we don't have, or very high-resolution phantom maps that are often incomplete and not of a high resolution. So the idea of having the sensory motor part together is basically just try to get more engagement of that network. But it might be that only sensory is required. But then there are practical problems on how we stimulate it. So